Hello, welcome to EPIC Session 6, Treating Trauma. My name is Tessa Lawler. I am a registered psychologist with Kells Counselling, and I'm also the clinical program supervisor as well. I'm really excited to go through some of this content with you today to help equip you to work with clients that may have experienced trauma. And we really wanted to give you some skills of how to sit in the room with trauma if somebody is having a big reaction or big feelings, and how to be able to prevent some of the abreactions that could happen as well. So let's first start with our message from Janet, who is the CEO and founder of Kells Counselling, and here's her message about working with clients with trauma. This session on treating trauma was written with the emerging therapist in mind. Our goal is to introduce core understandings that seasoned therapists use to assist clients to resolve wounding following traumatic injury. How a therapist works with a client can advance or derail healing. It is critical that therapists view clients as humans first. There is so much difference between having been victimized and being a victim. Being harmed does not mean that a person is broken or unfixable. Our clients are persons who have had a harmful experience that overwhelmed their internal coping systems and caused psychological injury. Neither psychological injury nor physical disease is a thing. Instead, both are processes within a human. We have a broken leg or diabetes. We are not the broken leg or diabetes. We have a post-traumatic stress reaction. We are not the reaction. Harm requires a healing process. Left unaddressed, either physical or psychological injuries can fester, abscess, and compromise the entire human system. In order to heal, we must identify the cause of the injury, acknowledge the harm, clean out the wound, and then provide direction and support to move forward in the process of healing. Supporting a client to heal from trauma is both a great responsibility and a privilege. We trust that the strategies and concepts that we have included in this session will equip you to support your clients as they identify not only their pain, but also their power to heal. So a wonderful starting message from Janet there about supporting clients with traumatic or psychological injury. We are going to cover quite a few topics today. And again, we want to arm you with some skills to be able to really be in the room with people who are experiencing trauma. So we're going to go over understanding and identifying trauma. What does that actually mean? What's the definition? And how can we start to look for the signs and signals in our clients that there may be some trauma in their history or maybe even in their present day-to-day as well? We want to talk about the difference between a traumatic reaction versus PTSD as a diagnosis. And we also want to talk about guided trauma processing. So how do we actually support clients to process their trauma safely and effectively? We also want to be examining avoidance, which is something that does come up with trauma. It is a really painful thing for people to be working through, and so avoidance is a natural thing that comes up. And we're also going to discuss post-traumatic growth as well, and how we can start to recognize that in our clients and help our clients recognize that in themselves as well. So let's get started first with the APA PTSD guidelines. Trauma is now recognized as extremely common in human experience. After traumatic exposure, the most favorable outcome occurs when post-traumatic reactions are naturalistically processed to a degree of resolution and do not subsequently develop into onerous or ongoing symptoms. When trauma is not spontaneously processed in this way, it can result in serious mental health consequences and symptoms, especially post-traumatic stress disorder, a condition usually accompanied by other mental health comorbidities and a range of medical conditions. Symptoms that are initially acute and that are not resolved can become chronic or can emerge and delayed from across the entire lifespan, causing anguish and suffering of the primary victim and loved ones as well. Due to the relatively high prevalence rate of PTSD in the general population, there is an urgent need for treatments that effectively ameliorate its symptoms. So some of the key things here is that trauma does need to be processed in order for people to be able to move forward and not experience more suffering in their lives. So what is trauma? What's the definition? So from Dr. Gabor Mate, he says trauma is not about what happens to you. Trauma is what happens inside of you as a result of what happens to you. So trauma is not about the external event that has happened. It is about how that person is impacted by that event. So it is the internalization of it. It is the feelings and emotions and thoughts that have happened to that person that have been internalized as a result of an event. So trauma itself means the wound, and it is defined by the person who experiences it. So what is traumatic for one person is not necessarily going to be traumatic for somebody else. Psychological injury can be caused by trauma, which can be defined as any unexpected situation where a person's physical, emotional, and or psychological level of distress has overwhelmed their personal protection system and compromised their ability to function in wellness and balance. So again, you notice there that it's more about the internal processes for the person and not about the event itself. Trauma is less about the event, and it's not the action that necessarily wounds us. It's what's going to happen inside of us that's causing that traumatic or psychological injury for us, which of course we know is invisible. And that's what makes trauma really hard to spot sometimes, is that we can't always see what's happening inside of a person if they are acting in, and those processes become invisible. So when we're looking at traumatic psychological injury, it creates chemical and emotional destabilization, which in turn can create a lot of other issues for the person as a result. So it can exacerbate a pre-existing condition, both a mental or physical condition. It can directly cause a disorder, an impairment, or a disability. It can trigger a post-traumatic stress disorder as well. So not everybody that has a psychological injury will meet the criteria for PTSD, but for some people, they will go on and they will meet the criteria for PTSD. It can also lead to mood dysregulation, such as depression, anxiety, phobias, fear, adjustment disorders, and a lot of physical illness or disease as well. Human systems are especially harmed by repetitive, excessive, or prolonged activation of the physiological and psychological stress response systems, which triggers the cascade of chemical emotions without adequate protection from protective factors. So when somebody's body is constantly in a stress response, there is prolonged damage physically and psychologically to that person because we're not meant to live in stress. And it's something that starts to create toxic stress for us when our body's system is not able to turn off. So unresolved psychological injury then can create lifelong suffering as a result. It can create damage both physically and emotionally and psychologically. There can be a lot of impairment that we see or dysfunction to a person, and that can even be relationally as well, and with somebody's capacity to be able to work or do the things that they were able to do before the traumatic injury occurred. So when we're looking at this, every stage of life has stress. So we know that stress is a part of life and it is inevitable. However, when we are exposed to a massive amount of stress or repetitive stress, it has an impact on us. And especially when the stress is experienced as a child or a youth and it's layered into the developmental structure of that person, it does create lifelong impairment or dysfunction if it's not processed or if that person isn't able to get adequate support. So if that person's body is now used to being in a stress response, it's going to have a massive effect on their ability to feel safe or feel calm or to be able to regulate their emotions as well. And there are many other consequences of having stress layered into the developmental structure of a person as well. While trauma at any age is devastating, it's especially harmful when someone's not fully grown. And not only is that because it's affecting them developmentally, but typically children and youth also have less control in their lives and they have less of a say of what happens to them. And so if that child is not getting support and they don't have somebody to talk to, if they're not even really sure of what's happening to them, we see that there's going to be more devastating effects for that young person as well. So, adverse childhood experiences. A child experiences toxic stress in the face of negative experiences when there are no buffering factors or access to protection. Toxic stress can be harmful when some or all of the following are present. The experience is intense or has strong emotional charge. The child feels helpless and is unable to process what is happening, and that is both in real time and after the event has happened. The experience carries on over a period of time, and that can also be repetitive events that happen over a period of time. The child lacks the presence of a safe and nurturing adult. The child lacks the protection of a safe person, and the experience is caused by an adult in a trusted position. So you can see how one of these things would be challenging for a young person, and when they start to stack on top of each other, that's where we really start to see more harmful effects for a young person. So looking at different adverse childhood experiences, here are some of the examples of what you will see on the ACEs test online. And you can actually take that test for yourself to see where you score and how many adverse childhood experiences you have encountered. And it is scored out of 10. This is not an inclusive list. This is just what is included on the ACEs test. So types of abuse: physical, emotional, and sexual abuse, neglect, physical and emotional neglect, and household dysfunction. So if there was domestic violence, if somebody in the home was experiencing mental illness, if there was parental substance abuse, if there was crime or an imprisoned family member, if there was experience of suicide or death of some type, and if there was divorce or separation. So again, this list is not exhaustive, but it does start to give a picture of what little humans can go through and how when these experiences stack on top of each other, we do start to see that it becomes harder for them to function both as little humans and as they grow as well, because these are happening during their developmental years. So there is a lifelong impact of these adverse childhood experiences. The risk for negative emotional, physical, or behavioral health outcomes has been found to have a dose-respondent relationship with over 40 negative outcomes to date. So what that means is, yes, somebody may have experienced one of those events that we described in the last slide, but if that person has experienced an event multiple times, it starts to create that dose-respondent relationship where the more exposure they've had to those events, the more negative outcomes that we see. So if there was one incidence of physical abuse versus 40 incidents of physical abuse, we're going to see that the person that was exposed to more of those experiences is going to have a harder time later. So we see that there are health issues associated with ACEs. So there's increased rates of heart disease, cancer, STDs, obesity, diabetes, suicide attempts, injuries in general, depression, stroke, COPD, liver disease, and disabilities. We also see that there's lowered potential for these humans. So there's lower academic achievement and graduation rates, and there's also work issues. So that can be challenges finding or keeping a job. And we also see that there are negative behaviors. So there's increased rates of substance use, smoking, addiction, abuse, domestic disruption, criminality, and social problems. So again, we're seeing here that the more the person is exposed to, the more challenges that they're likely going to face. So we want to be able to recognize these experiences in the humans that we work with so that we are aware of what they've been through and we can support them to move forward. So what we want to say is that what we address today, we prevent tomorrow. So this sounds really doom and gloom right now because we do see the negative outcomes and we want to recognize that yes, those negative outcomes are real. People are experiencing those challenges. And we also want to be instilling hope in the individuals that we work with and recognize that yes, that was hard. And what we are able to address and work with today is going to help create momentum and movement and growth for them moving forward. So we also want to be instilling that hope with them. We want to recognize, yes, that was challenging. Yes, that was hard. How can we be moving forward? How can we not let these adverse childhood experiences define where we go and what our lives look like moving forward? So here you'll see there's a graph that's just explaining some more of the facts about the ACEs and some of the issues that we might see with somebody that's experienced quite a few of those as well. So here you can actually take a moment and you can take the ACE test and find out your score. So you can go ahead and take a few minutes. You can pause this video and keep in mind that taking the ACE test can be activating for some people because it does bring up past events, and we are going to places that didn't feel great when they were happening and they may not feel great to think about now. So please take care of yourself. If you find that you are activated while you're taking this test, get some water, move your body. If you need to wrap yourself in a blanket or get a fidget, please do what you need to do while you're taking this test. This is just for information for you to be able to see what the test is and also maybe where you fall on it as well. Okay, welcome back. Hopefully you were able to take the ACE test just to get an idea of what it is and some of the items that are on that test as well. One thing that I want to mention is that the ACE test does not account for protective factors. So it does focus on the adverse childhood experiences, but it does not take into account an individual's protective factors or resiliencies. So something just to keep in mind moving forward. So do adults or kids manage trauma or adversity better? The answer is it really depends. As a general rule, adults can manage adversity better because they have an experience base of successful coping to reference, they have developed a neural network of systems, they have completed their developmental process, they have achieved levels of abstract thinking, they are more equipped to make sense of an experience, and they have more agency to respond to an adverse event as well. This generalization cannot be applied across the board to an individual, as there are many visible and invisible factors that impact each individual's capacity to respond to adversity. So if you look at the diagram here are some of the invisible and visible factors that can be both a protective factor or a vulnerability for an individual. So you see that there are a lot of different factors that need to be taken into account when you're working with an individual. So these are things that you can explore with them to figure out what they have for protective factors and what are their areas of vulnerability as well. So it's really important to keep in mind that an event does not necessarily mean there's going to be physical or psychological damage. Psychological or physical pressures impact humans on both a physical and psychological level. In reality, there is no separation between the mind and body. There is a bi-directional relationship between your brain and your body. Every experience, positive or negative, exists in both our body and our brain. We cannot separate those two. Life events and stressors, while problematic, may or may not harm us. The impact of each person's psychobiological system can only be determined once the person's personal factors and vulnerabilities are factored in. So once again, just because somebody has experienced an adverse event does not necessarily mean there's going to be a psychological injury that occurs. So if you take a look at the diagram here, we need to factor in the psychological demands. So what are their chronic stressors? What are the life events they're experiencing? What are their daily hassles and their physical health issues as well? So we need to look at what that person is experiencing in the present moment. And we need to filter that through an individual's protective factors and vulnerabilities. So what are their developmental assets? And we're going to go through that later. What are their current coping strategies that they have? Do they have any? Do they have resources? Do they have social supports that they can reach out to? What is even their personality? And also there's an element of luck here as well. Then we need to be looking at how those combine to create a person's psychobiological stress response. So it's really important that we don't make an assumption that just because somebody's been through these adverse events that there's been psychological injury or damage. And it's also important to keep in mind that even in a family system, if there's an adverse event that happens, somebody may experience psychological injury from that event and somebody else might not, based on the things that we have just discussed. So we're going to talk about how trauma impacts the brain. Something really important to note here is that trauma actually impacts every part of the brain, but we're just going to be focusing on three main areas. So the first is the prefrontal cortex. This is the part of the brain that is important for decision making, and it's our impulse control center. When trauma or toxic stress chemicals flood the brain, blood flow to the prefrontal region can decrease, which negatively impacts language, memory, and functional decision-making ability. Impulsivity becomes harder to manage as a result, so this is where we might see a spike in impulsivity or risk-taking behaviors. It can also become a struggle to stop inappropriate reactions, both relationally and emotionally. And our ability to focus attention or concentrate is harmed. We have a harder time being able to do the things that we used to be able to do. Unfortunately, when our brains are flooded with stress chemicals, the blood flow to the emotional areas of the brain can also increase. So this intensifies emotional experiences and reactions. So we might see an increase in irritability and sadness and anger. And it does not always assist well with coping skills and positive choices because that person may not be able to even access their coping skills in that moment because their prefrontal cortex is not getting as much blood flow as it normally does. And we see that when the prefrontal cortex is not getting the amount of blood flow that it needs, it impacts other centers of the brain as well. So the second area of the brain that we're going to focus on is the amygdala. The amygdala is the core of a neural system for processing fearful and threatening stimuli, including the detection of threat and activation of appropriate fear-related behaviors in response to threatening stimuli. So you can think about the amygdala as this little scanner in your brain that's constantly looking for threat in the environment. That's its whole job. So a traumatic experience or experiences can affect the amygdala in the following ways. So it activates the release of stress hormones more often or in a more intense way. It increases overall arousal levels. It increases fear-activated autonomic responses. It engages the brain's emotional response system. So that's where we start to see more emotionality or more inappropriate or unhelpful responses in situations that maybe that person is safe or that person is doing okay, but they're not feeling like they are. So their emotional responses aren't actually matching the situation. It decides which memories to store and where to store them. And it also applies feelings, tones, and emotions to different memories. And this is why trauma memories do tend to be more intense for people, because the amygdala is attaching fear to them. And we tend to really input those memories in a way that they're going to stick out. So the amygdala is making sure, hey, remember this? This was really scary and it happened. And it also, that memory gets encoded in a way that feels like it's happening in the present moment, which we'll talk about next. So the third area of the brain is the hippocampus. So the hippocampus is the region of the brain primarily responsible to regulate a person's motivation, learning, emotions, and memory. So traumatic overload prevents the brain from transforming short-term memories into long-term memories. And so these highly charged memories stay in the active and unresolved status. So what that means is that these trauma memories are not actually being properly consolidated in your memory, and they're not able to be properly integrated, so the effects of the experience can dissipate. Because they're not processed and consolidated properly like the rest of the non-trauma memories, they feel like they're still happening. They are feeling like they're happening in present time. And this is where we see flashbacks coming from, because these memories aren't properly integrated. And we're also seeing nightmares from this as well. So trauma also causes the hippocampus to shrink, which impacts both the ability to integrate past memories, but it also creates challenges in memory moving forward. So we see challenges in prospective memory. So the ability to remember that you need to go somewhere, or that you have an appointment, or that you were meant to do something as well. So it's important to keep this in mind for individuals that you work with, to help them understand that trauma and toxic stress, it impacts their brain. It is chemical and it is neurological, and there are things that are happening to them that are outside of their realm of control, which can feel scary, but it also can be alleviating for people to know, oh, okay, my brain's actually functioning differently as a response to the trauma and toxic stress I've had. This is not all my fault. And so it can really help people understand that there are changes that happen. It is important to keep in mind that although these changes sound really scary for people, that of course neuroplasticity is an incredible thing that our brains have. So we can constantly be growing, changing, healing, and creating new neural networks to be able to override some of these impacts of the brain. We also want to recognize trauma is stored in the body. So like we talked about before, there is a bidirectional relationship between your brain and your body. They are completely intertwined. So it would make sense that when a traumatic experience happens, the person's internal system becomes overwhelmed by the chemical cascade triggered by the distressing experience, and it's going to get stored in the body. That's going to have major effects in all of the systems in the body. This chemical flooding interferes with the ability of the brain and body to process as it would normally. So it's really interfering with your body's homeostasis at this point. When the memory can't be processed and consolidated, it becomes lodged in the brain with all the sights, sounds, thoughts, and feelings that were experienced at the time. In short, the negative thoughts and feelings from the event become trapped in the nervous system. So again, our bodies are now experiencing those trauma memories in real time, and we're experiencing those flashbacks in a really intense way because our body is in that memory still. It feels like it's still happening to us, even though it maybe happened 5 or 6 or 25 years ago. So when we're looking at the different systems in the body, there are different responses that an individual can have. And we're going to talk a little bit about the window of tolerance as well. So here are some common reactions that we see to trauma. So people can have re-experiencing symptoms. So this is intrusive memories, images, or flashbacks, as we've discussed. This can be also nightmares or just really upsetting dreams, and intense distress when reminded of the trauma or things that are related to the trauma. So it could be places, things, or people. Increased physical arousal. So we do see more of a hypervigilance. So people being more on edge, they're more likely to be scanning their environment for threats or even for ways to escape if they're feeling trapped or scared. There's an exaggerated startle response as well. So just more of a jumpiness. So sounds might be a little bit more scary for them. People that are coming out of their vision, out of their scope of vision, it might be scaring them a little bit more because they're not prepared for it. So they jump. There's more irritability, rage, or anger. There might be sleep problems. So this could be a person sleeping too much or not sleeping enough or just not feeling rested with the amount of sleep that they're getting. And we also see that poor concentration and attention. So they're just not able to cognitively function the way that they were able to prior to the trauma. We also see avoidance of trauma reminders. So avoidance of activities, places, or people that bring up trauma memories. Efforts to suppress thoughts and feelings about the trauma, so they don't even want to think about it. They don't even want to go there. And that is really where we see a lot of suppression happening. Avoidance of trauma-related conversations or topics. So they don't even want to hear about trauma. They don't want to hear about anything related to it because it feels too scary or too much. We also see numbness. So a loss of interest in important activities or things that brought them joy before. Maybe they're not engaging with it in the same way. Feeling detached or isolated from others. We see withdrawal, so decreased involvement, and that can be from other people, but that can also be from those activities that they might have engaged in before. Emotional numbness or a restricted range of feelings, so they're just feeling less than they were, or they're just feeling this numbness. They're not feeling very much at all. There's a change in sex drive or decreased intimacy, so the change in sex drive can be both going towards more sexuality or more sexual experiences or less sexuality and less sexual experiences. So there's a spectrum there, just like there is with the sleep disturbances. And hopelessness or a diminished sense of future life. So it might be really hard for them to even picture a future for themselves or to picture them moving forward because they're really focused in on where they are right now. They may be in that survival mode. So just some general problems that you may see: loss of trust with self or others, suspiciousness and paranoia, increased impatience or irritability, depressions or just struggle with regulating mood, increased use or misuse of substances, disproportionate feelings of shame or guilt, overestimations of danger in their environment. So again, that hypervigilance, but they are more likely to be looking for danger in their environment, relationship tension and issues connecting with people and with themselves, increased feelings of incompetence, and increased levels of self-doubt. So really struggling to trust themselves and to trust their decisions moving forward. When we look at common reactions to trauma, of course, it's going to impact relationships. So a lot of times, trauma events or toxic stress happen in relationships. So we do see those struggles relationally as well. So that can look like addiction issues. So we know that addictions can be both substances or behaviors. And the addiction can start to create a wedge in the relationships. It's almost like a third person getting involved because it can take up a lot of space and start to create a lot of issues for people. Both the person that's struggling with the addiction and the person that's on the other side or around them. We can see an increase in anger, and that can be really challenging in relationships because it makes people feel afraid. And sometimes people might start backing away going, holy, this person's getting really angry. I don't really want to be around them. There's grief. So a lot of times with trauma, we are not only grieving what has happened to us, but we also can be grieving what we've lost, or we're grieving our capacity because it's not the same. We might be grieving lives that we wish we had that we didn't. So there's a lot of layered in grief there, and that can create disruption in relationships as well. And that detachment that can happen. So this can be both for the person that's experiencing trauma or for the people on the other side as well. So that person may not want to be around other people, and vice versa. Other people may not want to be around that person. So there is a lot of detachment that can come. Intimacy. So this intimacy can be emotional, it can be physical, or it can be sexual as well. So it can be really challenging for people to get into that space, to feel close to other people, to want to engage with people in those ways. So we can see that there's a decrease in intimacy. And on the other side, we may start to see that for some people, they are increasing their intimacy with other people. They're really looking for that connection, and that can result in more impulsivity or some risk-taking behaviors as well when it comes to sexual intimacy. We see that there's an increase in stress and arousal, which of course is going to impact a relationship as well. So if somebody is having a hard time regulating their mood, or they're feeling a lot more hypervigilant, that's going to create a different tone in that relationship as well. And because we know that emotions are contagious, that stress and that hyperarousal can start to impact a whole system. Looking at sleep and fatigue that we touched on. So even things like people not being able to sleep in the same bed as their partners because they're having sleep issues. They may not be able to contribute in the ways that they were able to before because there's just so much fatigue. Maybe because they're having sleep issues, but also they could be experiencing chronic pain. They could be experiencing chronic fatigue because psychological injury can result in those things as well. And we see avoidance. So if that person is not feeling safe, they may also be avoiding people around them more. They might be avoiding things that they used to do, which of course can cause disruption as well. So an acute stress response is different from PTSD. So an acute stress response is a normal response to a harmful and overwhelming situation. So when you look at the chart here, somebody can experience a traumatic event or a stressful event, and they are going to have a normal stress response to that. And what we see is that after the event, shortly afterwards, that person's stress response diminishes, right? It decreases and they return back to baseline, to their normal baseline of stress. For other people, what can happen is that they stay in the stress response for a prolonged period of time. For some people, this can be weeks. For some people, this can be months and years. So when we think about PTSD, we like to reframe it as a prolonged traumatic stress disorder because it's a prolonged stress response and activation in the body that we see. So some people, again, are going to experience that acute stress, which is totally normal, and then they're going to be able to come back down and really return back to functioning. And they're going to be able to continue forward. And for some people, that's going to look different. And everybody's chart is going to be different based on, again, their protective factors and their vulnerabilities. So it's important to keep in mind processing out those traumas so that we can help that person not be in that prolonged stress response. So looking at PTSD versus trauma reactivity. So it's not necessary to pathologize symptoms or diagnoses. A strong diagnosis is useful as a frame for understanding areas where the client's struggling and identifying where they could benefit from support. So for some people, it really provides that strong framework. Experiencing a traumatic reaction or an acute stress response does not mean that somebody has a disorder. Some people will have trauma reactions, but they will not go on to develop a disorder. So with that PTSD diagnosis, somebody has to experience those symptoms for longer than 4 weeks. So for some people, they will have trauma reactivity or that acute stress response, and then they'll go back to baseline and they'll continue on with functioning where they were before the event occurred. By definition, a disorder creates significant disruption in more than one area of the person's life, and they can also experience some of the symptoms but not meet the full diagnostic criteria for PTSD. Really important here that mental injury does not necessarily mean a mental illness. So we want to be careful not to pathologize or overdiagnose people as well. We want to keep in mind that trauma reactions or acute stress responses, they're normal. That's how our body goes into that fight flight mode to protect us when we have experienced something distressing. And we have to keep in mind that yes, there may be symptoms that are happening for a person with a mental injury, but that does not necessarily mean that they have a mental illness. So looking here at the different elements, there's a lot of overlap that we see with different diagnoses. And that's why we want to be really careful when throwing out diagnoses or labels with people, because we have to be able to do something called differential diagnosis. We have to be able to say that this person meets the criteria for this and this only, or be able to say that they don't meet the criteria or fit it for something else. Because when you look at this diagram here, there is a ton of overlap, especially when it comes to trauma, because trauma impacts every system in the body, every part of your brain, and it can create a lot of those other general problems that we've gone over. It can look like something else, but it really could be a trauma response, or the person could also have PTSD, or they could have complex PTSD as well. So when we're looking at the difference between PTSD and complex PTSD, PTSD tends to be related to a single event or a cluster of similar events that may have happened. So for example, a car accident could be something that somebody experiences PTSD afterwards. Complex trauma is when somebody has been exposed to a lot of different events for a prolonged period of time. And complex trauma also tends to have occurred in the developmental years. It doesn't have to, but it can be some of those childhood experiences that we talked about that can start to layer on top of each other when somebody has experienced a range of adverse experiences over a prolonged period of time. So this is something that we just wanted to show you so that you keep in mind there is a lot of overlap. And so we do want to be careful when we are looking at diagnoses with people. And yes, it can provide a helpful framework, but we want to be careful not to do that carelessly and to not do that without doing our due diligence as well. So when mitigating psychological injury, movement really matters. And there's this really incredible video that you can watch in a moment where she talks about how skeletal muscles work in conjunction with the endocrine system to secrete myokines, which are a body's natural antidepressant medication. So really cool, quick video. I'll give you a moment to pause me and to watch that video. Enjoy. So hopefully you enjoyed that video. She's quite brilliant and she has a lot of really cool things to say. If you enjoyed that video, she's got a ton of other content online that you can check out as well. So now shifting into resiliency. This is a massive factor when we are working with people that have experienced trauma. We want to help them build resiliency and skills to move forward. We don't want the trauma or their experiences in the past to define who they are or where they're going. So developmental assets are something that you can explore with your clients. And we've provided you with a handout where you can actually go through for yourself and identify your external and internal assets. So when we're looking at the external assets, this is support, empowerment, boundaries and expectations, and constructive use of time. When we're looking at internal assets, this is commitment to learning, positive values, social competencies, and positive identity. And the way that we've designed these handouts is that you can go back to when you were a little child and you can look at the developmental assets that you had back then. How many did you have? And you can compare it with now. How many do you have now? And this can be a really great tool to use with clients to help see where do they already have resiliency? Where do they already have assets and skills and supports that are working well for them? And then what are the areas that they may need some more support in? How can we help them create more resiliency in those areas? We really want to help our clients build up their grit. So their guts, their resilience, their industriousness, and their tenacity, and really have that determination and courage to push through. And part of that is helping them have more developmental assets. So we know that the more developmental assets a client has, the more resiliency and the more skills and supports they're going to have to move forward and to move through. So take a moment, go through for yourself and see where you're at with your developmental assets. And maybe you'll notice an area in your own life that you can see some improvement or build some more skills in. And you can also use this as a tool with your clients as well. So I'll give you a moment, pause the video, and then we'll come back. So welcome back. Hopefully you found that to be a useful exercise for yourself, and hopefully you're thinking about some clients that you might be able to also use that with. So shifting next into externalizing and deactivating. So it's really crucial that we help our clients externalize their experiences and emotions in some way. If they do not externalize it, the body activation does not lose its charge and the body does not reconsolidate the overwhelming memory. So again, it stays stuck. Distress is not discharged and it sinks back into the body and it sinks back into their brains. So we really want to help clients empty these experiences out. And every client is going to like a different type of externalizing. And with that resentments, regrets, and wishes activity that you've already learned in this series, that is an incredible tool to use with clients, even at the beginning of a session. So sometimes clients come in and they are so emotionally charged. They've had so many things happen to them over the past couple weeks. And that is such an easy and quick way to help reduce the emotional charge that they're coming to the session with. Some people may want to speak out their resentments, regrets, and wishes. Some people may want to write it out and then read it to you. Find out what works for each person. Everybody's different. Your client doesn't have to remember every single thing that happened to them. They don't even have to have the words for it. We just want to also have them concentrate on the feelings and the sensations to be able to discharge that trauma reactivity. So sometimes clients will say, well, I can't really remember. I don't have images or I can't really explain it. We can still work with trauma because we're working with the sensations that the body has absorbed and we're working with the feelings in the body. If you can, and if the client is in a space to be able to do that, you can have them write down every single thing that they can think of that has happened and put it in an envelope or in a trauma container, and they can come back to it later. This is something you can hold on to for them as well. And they can write it down so that they know, they've let you know, and when they're ready, you will process those events with them. You can also use the emotion bucket that you've learned about. You can have them speak out things out loud to you. You can have them write it down and destroy it. And again, you can use those externalizing activities. The purpose of this is we want to deactivate by speaking out or by writing out and getting that out of their brains and their bodies in a safe way. The biggest thing when working with trauma is we want to do this in a way that is safe. We don't want to push people outside of their window of tolerance so that they're feeling unsafe. It's our job as clinicians to make sure that they are staying within their window when we're working with them, which we'll talk about a little bit later. So processing trauma. I've been talking about that this whole time. What does it mean? It's really critical to unblock and desensitize the stuck trauma reactivity to allow the experience to be processed and adaptively integrated. So again, we want that memory to be properly consolidated in the brain, and we want the reactivity in the body to be reduced. After a successful intervention, a memory is still going to remain. So we're not erasing people's minds here. What we're doing is neutralizing the negative response that they're having to that memory. Processing trauma helps reduce the emotionality and vividness of the memory. And we do work with the modality of EMDR here at Kells, and we do recommend that. It is a type of exposure therapy that helps an individual be desensitized to an event that has happened. And it does reduce the emotionality that is attached to that event for them. So when it comes to processing trauma in your room and in the space that you're in, it's really your job to set up a safe space. Trauma clients often have many sensory issues and sensitivities, and perhaps might even be related to their internal dysregulation. So if the lights are too bright, if the noise machine you have on is activating for them, if the window is open and there's sirens going by, that can also lead to dysregulation for people. So really important that we take each individual in mind when we are setting up the safe space. So we want it to be comfortable for them. We want it to feel safe for them, and we want them to be soothed in that environment as well. So for some people, they might like it if there are minimal distractions in the room. They might like dim lighting, so having lamps on or low lighting versus really intense fluorescence. They might like the blinds to be closed or partially closed so there's not bright sunlight. They might like background music, or maybe you do put on a noise machine and they can choose the sound that they like. You can provide them a weighted lap pad or a weighted blanket or something that they can put on their lap. So some people even like to hold pillows or blankets. And we can also encourage clients to bring their own things to session. So if they have something that feels really comforting to them, they can bring that in for themselves as well. We can have fidgets and tappers available. So we have TheraTappers that they can use that are going to provide that bilateral stimulation. So yes, we can use that for EMDR processing, but we can also have people hold those, put them under their legs, and just have them helping regulate their body while they're talking about really hard stuff. Something that's really important here is we want to ask them. We want this to be a collaborative experience for the client. So really, what's going to work best for them? What's going to make them feel the most comfortable? And have them involved in that process, because ultimately they're going to know best what's going to feel good. And they can try out different things. So maybe they try out the TheraTappers and they don't like them. Maybe they really liked the low lighting. So figure that out with them, and keep in mind everybody is different. So when it comes to establishing safety, it is the therapist's responsibility to create safety in session. So to do so, it is best to adapt an active role versus a passive role when we're working with people who have experienced trauma. So really, you want to think about the therapist role as a conductor of a symphony. So you are in charge of what is happening when we're taking breaks, because you're going to be noticing, is that person getting flooded with emotions? Are they getting really activated? And do we need to help them slow down and breathe? Do we need to take a break? It is the therapist's responsibility to be watching for those signs and signals in the client to be able to conduct the session and to conduct the processing in a safe way. You want to share with them that you're going to absolutely hold space for their stories and emotions. This creates trust and safety. So some people that come into session have never had anybody validate them before. They've never had anybody just listen to them and say, yeah, wow, that sounds really hard. So establishing that up front with somebody is really important, saying, I'm going to be able to hold space for what you bring into session. That's my job. I'm going to be able to sit here with you when it's hard, when it's easy, when it's light, when it's not so light. So really establishing that trust with them off the get-go. You want to ensure that you have a pre-established safety plan or coping plan. So if somebody is having a big emotion or they become activated, you want to be prepared for what you're going to do. So are you going to go and grab ice to have them hold on their eyes or behind their neck, as you've learned about the tip skill? Are you going to get them to get up and move their body? Are you going to cue them for breathing? Are you going to do that in a certain way? And again, this is a collaborative process with the client. You want to be discussing these things with them so you have a plan established. You also want to be listening under the core messages. So clients come in sometimes and they can say so many different things and they're talking about all these different things, and it's really your job to pull in the themes and the core messages and help make sense of all of the stuff that they're bringing. You want to be looking for those threads, and how can you help them make sense of what they're experiencing as well. And again, validating their process and their experiences. So reminding them that they are in charge of this process. So yes, you are the therapist, you are the conductor. However, they are allowed to go at their own pace. They are allowed to tell you as much or as little as they want, and they are allowed to decide what they talk about and when. That's really important. And we'll talk a bit about avoidance and how that can come in and how to navigate that. But ultimately, the client needs to feel safe and they need to feel empowered that it is on their terms. We also want to know when to shift or discontinue. So if you are finding that the person is really activated and you only have 10 minutes of the session left, you do not want to continue processing. You want to make sure that you are allowing enough time at the end of a session to help a person be able to return back to baseline. We do not want people leaving the session unraveled, feeling raw or feeling exposed. Yes, there are going to be times where you're doing some deep work and people are going to be in that space, but we do not want them leaving the session in that way. So making sure that if you're recognizing you're working with someone that's getting really activated, you might need 20 minutes of the session to help them self-soothe, to help them regulate their body and to feel calm and safe before they leave the space. That is your responsibility, to be watching for that and planning for that. So as the conductor, that also comes with time management. That is on you. How much time does that person need to be able to feel okay before they leave? So again, wanting to look at if they're abreacting, we really want to be stopping the processing earlier. and we want to be allowing for more time. And we're going to talk about abreaction because we want to avoid abreaction at all costs. So we do not want clients leaving raw or exposed. We want to help them feel grounded again. And that's where some of that planning ahead of time is really important. Having them collaborate with you about what's going to be best is important. When it comes to processing trauma, client readiness is a really important factor. So there are some clients who may not be ready to process their trauma yet, and they're going to need more time to build emotion regulation skills and to stabilize. And this is a really important piece. So sometimes we get so excited, we want to process trauma with somebody, we know it's going to help them, they've been carrying this weight for 30 years, they may not be ready. If somebody is not able to regulate or use skills or strategies, it is not safe to process trauma with them yet. So even though you're excited as the clinician, you're ready, you're like, yes, I've got all these amazing skills, that person may not be able to safely do that. In fact, they will not be able to safely process trauma if they cannot work with their body and regulate themselves. So again, it is your responsibility to help a client determine when they're ready to begin processing their trauma. If we work with clients who are not ready and they start processing before they have the skills and before they're in a stable place, we can harm them. This is where we see abreactions. This is where we see that people start to re-experience trauma at a faster or more intense rate, and they may be reactivated beyond their ability to cope, and they might start to deteriorate further. So if we do this before they are ready, we are harming them. We have the potential to harm them, and chances are they actually won't come back. So we see that if a client is pushed so far outside of their ability to manage that they don't come back to therapy because it wasn't a positive experience, they didn't leave there feeling good, they left feeling worse, and they are now deteriorating than when we saw them, right? So we want to make sure that a person is ready. We want to be ensuring that they have skills and the ability to stabilize, and that they're in a safe place in their life to be able to do that as well. So here are some signs of readiness. This is what we want to look for. So a client might be ready to reprocess their trauma when they have these following things. So when they have developed skills for emotion regulation, so they know the skills that are going to work best for them, and they're able to use their skills to get back into their window of tolerance. So they're aware of their window of tolerance, and they can tell when they're getting outside of their window. So are they able to stay within that for the most part? And if they get out of their window of tolerance, so that optimal zone of arousal to handle stress, if they can use the skills to get back in the window, that's excellent. They are demonstrating inside session and outside session that they can use these skills. They also have a safe environment to return to. So if they are processing a trauma, but they are actively living in an unsafe or harmful environment, it may not be safe for them to be processing at that time because they're not going back to a safe place. They are also able to identify external supports that can help them as well. So this could be family members, friends, other healthcare professionals that are on their team. They also are able to establish a target to work on. So they're really clear on what they want to work on and where they want to go. They also have a coping plan, both for during session, right? So if they become activated, they have a plan for that, and they have a plan for after session. How are they going to take care of themselves? After processing trauma, people can feel a little bit raw for a couple days, and not to the sense where they're so far out of their window, but sometimes they can just feel a little bit more raw. So what can they do after those sessions? You know, the night of, the next day, how are they going to cope? And they're also able to create their own internal space, and they can stay safe in their body. And we really want to be looking for these things because this is telling us, okay, this person is going to be okay once we start processing trauma. Yes, it's going to be challenging. However, they are demonstrating that they have the skills, the supports, and the ability to be able to go back and process. So the window of tolerance, as I mentioned previously, this is the person's optimal zone of arousal to function in everyday life and to handle stress. So some people have a smaller window of tolerance and some people have a more expanded window of tolerance. And this can also change depending on the psychological demands in their present day. So if they're having more stress, they might have a smaller window. If they're having less stress, they might have a bit more of an expanded window. So when someone's operating within their window of tolerance, they're more effectively able to deal with stress and manage their emotions. Stress or trauma can shrink the window, and it doesn't take a lot to tip somebody outside of it. So depending on a person's nature and skill set, they can become hyper-aroused or hypo-aroused. And some people can also become hypo or hyper-aroused depending on the situation or who's around them as well. So when we're looking at hyper-arousal, the body's systems are becoming overloaded, and this is where the fight or flight response gets activated. So the body's reactions are not something that the person is choosing, they are involuntary reactions. When we're looking at hypoarousal, whatever is going on is too much for the body's system, so the body actually just closes down, it shuts off, and this is where we see numbness, the brain going offline, and this is where that freeze response comes in as well. So it's really important to be able to recognize when somebody is operating outside of their window of tolerance, because we want to be able to help them get back into their window. That's where they're going to feel safe, and that's where they're also going to be able to process best. So with hypoarousal, here are some signs that will indicate to you somebody is now outside of their window. So there may be a helplessness or a defeated energy, so they might actually even appear lifeless, and their body stature might really become more caved in, or they might become a lot more closed off. They can also just become non-expressive and have flat emotions, a lack of motivation. They might appear tired or have a dulled capacity to feel. So again, that numbness. There's going to be a lower mood or depression and a withdrawing that happens. And we also see dissociation with hypoarousal as well. So ensuring that if your client's body language has changed, or they're starting to really cave in, or maybe they're not looking at you as much and they're shutting down, you want to be looking for those signs in their body that they are becoming hypoaroused. On the other side, here are some signs that somebody is becoming hyper-aroused. So they might start to breathe a lot more intensely. They've got more of an increased heart rate, which is increasing their breath. They may start to become anxious or agitated. So maybe they're fidgeting a lot more. They're a little bit more restless. You're starting to see that they're more disorganized or presenting as overwhelmed. They can also be disconnected and dissociated in a hyper-aroused state as well. So they may not be as connected with you or as present in the room. They may be more irritable or more aggressive, and they may just have more intense emotional responses as they're hyper-aroused. So again, wanting to be looking for these signs so that you can help them become more regulated as they're in a dysregulated state. That's really our job, to be looking for those signs. So here's how you can tell somebody is within their window of tolerance. So they're able to notice how they're breathing. They're able to regulate that breath as well. They can make comfortable eye contact with you. They're confident, they're poised, they're able to feel grounded and centered in the space. They're able to maintain an awareness of their body and their mind, and they can notice those body sensations and they can name them for you. They might need support with that, but they can acknowledge that they're there and get support naming them. They can think logically and in an organized way, and it's clear. They can make conscious choices. They can respond to your questions in a way that makes sense. They can have a range of emotional expressions. They're communicating clearly, and they also have a maintenance of stable sleep cycles. So some of these things are going to be both within and outside the session. So things to keep in mind as well when we're looking for, is this person ready to process trauma? We're also asking, can they stay within their window of tolerance as we're processing, and can they stay within their window outside of the session? And if they're getting out of their window, are they able to get themselves back in? So looking at emotion regulation skills, as we talked about, really important that before we process trauma with somebody, that they have some skills to be able to manage some intense feelings that are naturally going to come up. So it's completely normal for clients to have strong emotional reactions when they are processing trauma. It is painful. It is hard. It is exhausting. Sometimes people don't want to do it because they're frustrated that they even have to do it. So we have to keep in mind that these are going to be normal reactions. And it's really our job to support them. It's our job to model and accept their range of emotions, and we need to be comfortable with that. So even if somebody is having a big response and they're angry and they're frustrated, we want to be a pillar of peace. We want to be able to hold space for that and go, absolutely, yes. And in a way that makes them feel comfortable and safe so that they know we're holding space for them. And we also have the skills to help them regulate as well. So we don't want them to stay in an activated state for too long because that can be harmful for them as well. So yes, we want them to express their range of emotions, and then we want to be prepared with the skills and strategies to be able to support them to be regulating. So before you even begin processing trauma with the client, they need to have an imaginal safe space. So this is a concept from EMDR. So they need to be able to have a place in their mind that they can go to and imagine is safe and feels good for them. And they also need maybe a safe place in real life. So is that a hammock in their backyard? Do they have a best friend's house that they really like going to? Do they have a dog park that feels really safe for them? We want to help them establish safety so that they have places they can go to both in their imagination and in their real lives, because we want them to be able to start moving towards that safety piece. So with trauma, they're feeling unsafe in their bodies already. They're feeling unsafe in the world and with people around them. So how can we help them start to establish that safety for themselves? One of the biggest things that is going to be helpful is having things ready by your chair or in the space where it's accessible. So having fidgets available, having your TheraTappers available, blankets ready, bean bags or weighted lap pads ready for grounding them if they need it. Of course, you can't keep ice with you because it would melt, but having ice ready in the freezer so that you can go and get that if it's needed. And if that's somebody needing some support being regulated, the more prepared you are, the better you will be able to help somebody become regulated and hold that space for them, because you're going to know what to do next. So when we're looking at dissociation and abreaction, they are different. And we really want to avoid abreaction because it is very harmful to a client. And that's where we were mentioning that people may not return to session if they are abreacting, if we have caused something to be stirred up in them that they were not prepared for or ready for. And yes, some things are going to happen in session that we can't control for, but abreaction is something we absolutely do not want to happen. So an abreaction is the expression of previously repressed emotions and sensory experiences. They can be spontaneously activated by an inadvertent reminder of an unconsolidated trauma or through a deliberate intervention such as EMDR or hypnosis, right? So people who are experiencing an unguided abreaction can be harmed, and they feel like they're reliving the event in the present moment. And they can sometimes even go back into that space of maybe feeling like a 5-year-old child, and they can be very, very challenging to help soothe because they are not present in the moment. So if that happens, it is absolutely critical that you are prepared to get ice, to help them breathe, to change the movement in their body, to get them on the floor if that feels good, but being prepared for what to do if there's an abreaction, because if they stay in that state, it is very harmful for them. So it's critical that any therapist working with a traumatized person is able to assist them to reprocess a trauma memory when they are equipped and ready to do so, and when abreaction is least likely to happen. So again, they have those skills and they are able to demonstrate those skills to you. On the other side, dissociation is a disconnection between a person's thoughts, memories, feelings, actions, or sense of who they are. When a person dissociates, they feel disconnected from themselves and from the world around them. It is a normal coping process, and all of us have experienced dissociation at some point in our lives, and it is a spectrum. So it does range from daydreaming all the way to a dissociative identity disorder. So there's a massive range of dissociation, and it is a normal response, and it is a coping mechanism that somebody may have used to be able to get through some really distressing moments that they weren't able to escape from, or they weren't able to have any control in. So dissociation as a coping mechanism can become problematic if it's not directed by the person. So if they can't shift out of the dissociative state, or if they can't recognize that. And if you are working with somebody who experiences dissociation, you really want to be working with that person to help them stay as grounded as possible. So using strategies like weight, using strategies like physical items that they can hold on to, that they can feel, so that they know their body is in that present moment, in that room with you when they're processing trauma. Really important when we're processing trauma. If you're using a modality like EMDR, you can also say to that person, it's June 25th, you're here in the room with me, you are 32 years old. So you can cue them in the present moment of where they are and who they are and how old they are to help them stay grounded in that moment as well. So there is more work that needs to be done on the clinician side to be working with people who are dissociative, and that's where extra training and tools will come in handy. So we really want to avoid unguided abreaction. So again, if your client abreacts and they're reliving the trauma, there are strategies that you can use to recenter them in the present. Like I mentioned before, this is something we want to avoid, and we really want to avoid that by being prepared and doing the work ahead of time before we process trauma with people. First, we need that client to use paced breathing. So we need to be able to connect with that person and say, hey, you're here with me. You're in this space. You're okay. Let's breathe. And you're going to do this with them. So it's really important as the therapist to model these strategies and do it with them. So if they're holding ice under their eyes, you're holding ice under your eyes. If they're doing a paced breath, you're doing it with them. And you want to really be modeling that and co-regulating with them. So first thing is first, we have to get that person breathing. So we know that the body is regulated by the breath. So you've learned about paced breathing when you learned your tip skills. When we're starting with a paced breath, we always start with the exhale. So the exhale is where the body releases the tension and the heart rate gets slowed down. So a long, slow exhale through the mouth, a sharp inhale, really quick through the nose, 1 to 2 seconds, and then long and slow out. We want to be cueing that person as they're breathing, that they're with us, that it's okay, that they're in this space, they're 32 years old, and we want to also be helping them get back into their body. So that could be using things like brain gym or movement. So after they've done some breaths and they're starting to visibly look like they're getting a little bit more regulated, you can get them up and moving. So doing some exercises, some stretching. You can have them even just sway back and forth on their feet. You can have them use the TheraTappers or tapping, using the tip skills again. So that's where you could be bringing in ice as well. So if you have to leave the office to go get ice from a freezer, you want to make sure that you've helped them regulate their breath and that they're back in their body before you go grab the ice. Ice is an incredible skill to be able to use with somebody. It's so helpful, but you don't want to leave a person in that office by themselves until they have regulated their breathing, because that can be harmful for them. You can do things like mindfulness. You can do grounding activities, fidgets, beanbags, weighted blankets. So if they're feeling like they're not present, get something on their lap that they can feel, have something in their hands that they can hold. You can have them change their posture by switching seats with them in the room. So maybe they're in the therapist chair, maybe you both get on the ground. Whatever is going to help that person, we need to get them back into their body immediately and back into the space immediately. That is the number one thing that we need to do. So when we're looking at the different ways that people may respond to distress or stressful situations, there are 4 main categories that we see, and you're probably familiar with them: fight, flight, freeze, and fake. And we've actually renamed them as protective strategies because we thought that that was a lot more empowering than the term trauma response. Yes, these are responses to something that is happening to a person, but we really see them as ways that this person has been able to protect themselves or was doing the best that they could with what they had to protect themselves. So looking over the different types of protective strategies, people may be more likely to use a strategy in a certain situation or with certain people, but we tend to use all of them. We may just have a tendency to use 1 or 2 more than the others. So if you're looking at the urge to fight or the urge to flee, that's activating the sympathetic nervous system. So it's really when you're in that hyper-aroused state, you're getting ready, you're getting armed to respond. And there's a lot of energy and activation that comes along with those protective strategies. Whether it's wanting to fight, lash out, or it's wanting to flee, you're wanting to get away. On the other side, the urge to freeze or the urge to fake is activating the dorsal vagal system. So this is where you're really seeing an underactivation and they're hypo-aroused and they're not able to function in the same way that they could before. So there could be a lot of numbness, some spacing out, a lot of immobilization or even collapsing. When we're looking at the urge to fake, we see that this tends to show up in ways that looks like people pleasing, where they're avoiding conflict, they're struggling with maybe codependency or prioritizing others over them. And that we see often when there's a power imbalance. So if an individual does not have power in a situation or is quite vulnerable, they may engage in the fake response to be able to navigate a power imbalance. So we want to help clients see that these responses are protective, that they are the ways that their brains and bodies are trying to help them in a situation where they're feeling distressed or activated. We don't want to shame or judge these protective strategies because at one point they were helpful. At one point, this is what they had to do to survive. And we really want that to be the message. People can be extremely hard on themselves when they think about protective strategies, when they think about their responses, both past and present. And it is our job to help reframe them and help them see, hey, this is what you knew how to do. This is the best way that you could have adapted to that situation that was really challenging, where you didn't have a lot of say. And we can recognize that that protective strategy was helpful in the past, and it may not be helpful in the present moment. So here are some of the ways that the protective strategies can actually be helpful. And we can start to help our clients see that this is how they were doing the best that they could. So looking under each of these categories, these are just some examples, but you can work with your client and ask them, how did that protective strategy help you? How did it help you get through that really challenging time? And start to really reframe it for them. What we want to help them do is recognize the protective strategy. So they need to recognize which one are they more likely to go with, which one's more likely to show up for them in these situations. And how can we help them see how it's maybe not helping them? And once they're able to build the awareness without shame, without judgment, we can start to shift into curiosity. And now we can start to say, I wonder why that's showing up for me here. What do I need to do to be able to feel safe in this situation? What do I need to do to be able to feel safe in this relationship? And that's where we can really start to build those resiliency skills. So curiosity is one of our greatest skills to be able to work with trauma. So rather than feeling shame, we can start to become curious about these things, and we can help our clients be curious about them as well. So using a protective strategy during adversity or a traumatic experience was the smartest, most adaptive thing a person could have done in that moment. And this is the message we want to get across to clients. That was the instinctive, protective part of you that stepped in to help you in those challenging times. The ability to access a protective strategy is actually to be validated. So once again, we want to validate it. We want to be curious about it. We want to reframe it. And we want to help them see, how did this help you? How did your body's ability to go into that response help you? And how is it maybe not helping now? And we want to be able to tease that out with them a little bit more, because it may not be the most adaptive thing in their current lives. So we really, again, want to be promoting that curiosity when it comes to the strategies. So we've touched on avoidance and how that can show up when somebody has experienced trauma or when somebody's coming to therapy and they're going to be working through their trauma. It is a key feature of trauma reactivity and PTSD. It would make sense that people would want to avoid things that don't feel great, and they would want to seek out things that make them feel good. So avoidance, like dissociation, actually begins as a coping mechanism to give time for that person to process what's going on for them and to be able to manage their intense emotions. Again, that makes sense. We want to recognize if that person is staying in that avoidance and if they're able to shift out of it. So people will go to great lengths to avoid people, places, objects, thoughts, emotions that remind them of the trauma. People are very skilled at how they can avoid. So it can show up in the therapeutic process when they want to avoid working through the trauma or talking about things that are related to the trauma. And this can happen where maybe you've made a plan to do some processing with them in the session, and they show up and they start talking about something that may not be as important, but it feels really important to them. And they're going on and on and on, maybe about this fight that they had with this person in a bookstore. And you're thinking, okay, we did have this plan to process trauma. Could this potentially be an avoidance strategy so that they don't have to process their trauma? Or is this something that's really important to them? So we want to gently call that out. We want to do a check-in with them because we want to see, okay, is this fight with a person at a bookstore really, really important in what you want to do today? Or is this a way to maybe get out of the trauma processing we had talked about? So we can do that in a way that's really kind and in a way that's just checking in, because people are very skilled at avoiding things when it comes to trauma and when it comes to doing the work sometimes. And we really, again, we want to do that gently and within balance, because we want that person to feel like they are guiding the process and they're choosing what they want to work on. And we want to balance that out with, could this maybe be a little bit of avoidance? The reality is avoidance uses more emotional and mental energy that could actually be repurposed for positive forward-facing life energy. It takes a massive amount to avoid things. And so helping people recognize that and understand that while avoidance can be helpful at first, it does eventually lead to more harm going forward in the long run. So we want to help clients determine what they're avoiding, and we want to call that out gently. We want to just say, hey, is it possible you're maybe avoiding here? And if humor is something you use in your practice, it can be a really good way to broach avoidance, is using humor. We also want to help them see that it is normal that they want to avoid this. It's normal that they don't want to talk about these things. And then, of course, we want to guide them towards avoiding avoidance. This is an incredible topic to talk about, and I'm so excited that we have the opportunity to talk about post-traumatic growth. We hear a lot about trauma. We hear a lot about post-traumatic stress disorder and acute stress responses, and this is often something that doesn't get talked about as much. And post-traumatic growth is really an incredible thing to talk about with clients, to help them see ways that they may have grown and healed, and parts of themselves that they didn't even know were there have surfaced as a result of going through something really challenging. So post-traumatic growth is the collection of all the positive, life-enhancing, healthy internal and external changes an individual has made as they handle the traumatic event. So it consists of internal changes such as personality traits, intelligences, values, attitudes, beliefs, and perspectives, and also external changes such as behavior patterns, life choices, strategies, and interpersonal relationships. Really important to note that post-traumatic growth comes at a great cost to the individual. Adversity can refine and build skills within humans. We know that. We know that if we go through challenges, we tend to be stronger and we're more equipped for challenges going forward. However, trauma is not the ideal setup or life context for growth to occur. So we are not saying, yay, this trauma happened. Aren't you happy it happened because now you're a stronger individual? It is not ideal. It would be fabulous if these things did not happen at all. However, an argument can be made that there are certain things you can only learn through trauma and specific cases in which trauma was the best context for growth at the time. The risk of being fragmented by prolonged trauma symptoms, however, is real, and it is a potential. So we want to be careful with how we're presenting this to people as well. We are not saying we are happy that these things have happened to them. We're glad that they're happened because look at where they are. It's really saying, okay, this happened. That sucked. It would have been great if that didn't happen. How can we see the ways that you have grown? How can we see the ways that you have moved forward and persevered and built up resiliency in spite of this really bad stuff that has happened to you? So we want to present it in that way because it can come off like we are saying trauma is an ideal setup for growth when it is not. It is overly idealistic to try to envision trauma as a terrific opportunity for growth. But there is an opportunity that comes when we can sort the seeds from the weeds and we can nurture new growth with insight, compassion, curiosity, and with some skills as well. So we can help clients see this in themselves, and we can see that Typically, PTG occurs gradually, and sometimes it can take years to manifest itself. It can coexist with PTSD and with trauma reactivity, but it does usually arise once a person's trauma symptoms have been diminished or they've been worked through. So PTG and healing from trauma is about embracing change, living in the moment, and standing in that transitional space between who they were and who they're becoming now. So it's really that idea that we want to help people not define themselves by the traumas, not define themselves by the past. We want them to be able to say, that happened to me, that was real, that sucked. And who am I now? Who do I want to be moving forward? And how do I want to keep growing? How do I want to persevere? And we want to help them really start to see their self-definition outside of the trauma as well. They are more than what has happened to them. So when we're looking at post-traumatic growth, there are internal changes that a person can experience. So when we accept and choose to grow through trauma, then internal wisdom, insight, and growth can emerge. So we can see strengths in unique intelligences, practical intelligences, values, beliefs, and perspectives. We really want to help clients take time to note and claim their gains. There's also external changes that can happen as well. So when we grow internally, our external life can show our gains. And these are things that we can maybe see a little bit more easily. So there can be gains in self-respect, how we treat ourselves, consciously constructing our lives, communication, life choices, problem solving, relationships, recognizing real problems, and recognizing behavior patterns that maybe aren't working for us anymore. So here we have created a post-traumatic growth wheel with 5 domains: spiritual development, personal strength, close relationships, greater appreciation for life, and new possibilities. And under each of these domains, you'll see that there's a change catalyst, recognition of the domain, wisdom that's been gained, improved qualities as a result, and positive coping mechanisms. So we have created an example here for you to be able to see how you could go through each of these domains with a client and have them break down each domain into these categories. We've also provided you with a blank one as well that you can fill out for both yourself, and this is a tool that you could use with clients moving forward. So it's just something that's more tangible for them to be able to work with. You can give them a list of post-traumatic growth like we did in the previous slides. Give them some examples, help them identify some of those things that they're seeing in themselves. And now they can break it down into these domains and they can really start to explore some of the wisdom and some of the values and some of the coping mechanisms that they have for each of them as well. So thank you so much for joining us today for this session. It has been a pleasure to talk about this with you and to be able to share some of the strategies and skills for working with trauma. Hopefully you feel more armed with knowledge and skills and resources to be able to work with clients that have experienced trauma or that are experiencing trauma. So if you're interested in learning more, here are some clinician resources for you. So the APA diagnostic criteria for PTSD, the DSM-5 diagnostic criteria for PTSD, Marcia M. Linehan's DBT skills training. So this is where there are going to be a lot of emotion regulation and distress tolerance skills that you can teach your client in the phase before you start processing trauma with them. The International Society for Traumatic Stress Studies, if you're interested in learning more. And then we do also recommend EMDR training so that you have skills and you have a modality to be able to effectively process trauma with the clients that you're working with. It is considered the gold standard for trauma processing, and it has shown to be effective for a number of individuals with a lot of different presenting concerns and traumatic experiences. Thank you so much for spending this time with me today. We wish you the best of luck as you are learning and as you are growing as clinicians, and we will see you in our next session.